My name is Olivia Roman. I'm a third-year Vanderbilt medical student, and I will be discussing emergency department usage by older adults at the end of life and strategies for improving healthcare quality for dying patients. Our objectives for today include understanding the epidemiology of emergency department use by older adults nearing the end of life and the impact of these visits on healthcare quality and cost. We will learn how to identify patients in the emergency department who may be nearing the end of life and how to have the all-important goals of care discussion with those patients. Finally, we will refresh our knowledge of hospice and palliative care so that we can have informed discussions about them with patients. Much of what we know about the epidemiology of emergency department use by older adults comes from the Health and Retirement Study. This was a longitudinal study of 10,364 older adults from 1992 to 2006. In order to understand emergency department use in this study population, the authors performed an analysis of the 4,158 participants who died during the course of the study. Using Medicare reimbursement data for these individuals, they reported the findings shown in the graph below. Specifically, 75% of participants who had died visited the emergency department during the last 6 months of life, and 41% of those individuals visited more than once. In the last month of life, 51% visited, with 12% visiting more than once in that time period. In addition, they found that nearly 10% came to the emergency department on the final day of life. The study authors also wanted to understand which patient characteristics were independently associated with emergency department use in the last month of life. They found increased use by patients 85 years or older, by those with a chronic condition such as cancer or heart disease, by individuals with ADL dependency or cognitive impairment, and by those with moderate or severe pain. On the other hand, they also found that patients who were enrolled in hospice were significantly less likely to go to the emergency department in the last month of life. Another important question to answer was what kind of impact these visits have on the cost and quality of care at the end of life. The Health and Retirement Study found that 77% of patients who came to the emergency department in the last month of life ended up in the hospital, and over a third of those individuals were admitted to the ICU. Even more strikingly, over 2/3 of the people who were admitted to the hospital died there. This is significant because when a patient is admitted to the hospital, they usually undergo additional diagnostic testing and other interventions that increase healthcare costs. And while in some cases, hospitalization is beneficial for patients near the end of life, it can also result in the patient being subjected to additional pain or other harm with questionable benefit. Interestingly, a study by Zhang et al. In Archives of Internal Medicine demonstrating the findings shown at the right that the higher the cost of healthcare in the last week of life, the lower the caregiver-rated quality of the patient's death. This data, combined with what was learned from the Health and Retirement Study, suggests that by working to reduce unnecessary healthcare utilization at the end of life, we can potentially improve the quality of care a patient receives during their final days. As the gatekeepers to the hospital, emergency department providers can lead the way in these efforts. To do so, providers must know how to identify patients nearing the end of life, whether death is imminent or the patient's expected lifespan is significantly shortened. Once these patients have been identified, a key step is to determine whether an advanced care plan is in place. Of note, the Health and Retirement Study results found that at least half of older adults do not already have a plan in place during the last 6 months of life. If there is no advanced care plan, a goals of care discussion ideally should be completed as soon as possible. Finally, providers should have a low threshold for involving palliative care specialists, and in some cases should also be prepared to discuss hospice with patients and their family members. The first step in this process is being able to identify patients who are near the end of life. Let's start by discussing some of the signs of imminent death, which are also common reasons for patients to be brought to the emergency department in the first place. In general, caregivers may note that the patient has had decreased hunger or thirst, and has been sleeping for greater and greater portions of the day. The patient may have signs of reduced cardiac output, such as hypotension and tachycardia, levator reticularis, and cyanosis of the extremities. Respiratory decline may be manifested as dyspnea, Cheyne-Stokes breathing, or the so-called death rattle, caused by pooling of oral secretions in the back of the throat. Additionally, many actively dying patients have a reduced level of consciousness, may be disoriented or agitated, and sometimes have hallucinations. When a patient with a life-limiting illness has these signs, suspicion should be high that death is approaching. It is also very important and often more challenging, especially with the time constraints imposed by working in the emergency department, to identify patients who have a shortened expected lifespan. A good rule of thumb is that if you find yourself thinking that you would be surprised to learn that a particular patient were still alive in 12 months' time, you should consider investigating further. You can review their chart to see if a prognosis has already been given. You can try contacting the patient's doctors, or even ask the patient and family about it yourself. If no prognosis has been discussed, you may choose to research the patient's condition to get a better idea of what the prognosis might be. One useful resource is the website eprognosis.ucsf.edu. This is a website that contains a repository of the most commonly used prognostication scales and can help you choose the one that best applies to your patient. In general, though, some characteristics, if present, can suggest that your patient may be approaching the end of life. This includes advanced age. Recall that almost half of health and retirement study participants over the age of 85 went to the emergency department in the month before they died. Having a chronic disease that has caused consistent decline or even has abruptly and significantly gotten worse. Bounce-back patients who have repeatedly come to the emergency department or hospital for the same problem. Patients who require a lot of assistance with ADLs and IADLs, and those who have had unintentional weight loss. These are some of the things that can help clue you in to a patient who may have a poor prognosis. So let's say you have now determined that your patient may only have a short time left. Let's also say, like many other older adults, the patient does not have an advanced care plan in place. It's time to have a goals of care discussion, which can make a big difference in the patient's trajectory. Admittedly, these discussions are often time and energy consuming, and research has shown that many emergency physicians feel undertrained in this skill set, which can make the process even more time and energy consuming. If you do not feel capable of having the discussion yourself, consider involving the palliative care team if they are available. However, a relatively simple strategy for talking to patients about goals of care is shown here. If you have the patient and family's permission, start by calmly and clearly communicating the prognosis. Knowing the prognosis can help the patient and the family then decide what they value most for the time that is left. Based on those values, offer the available options, making it clear what you believe will help their goals to be achieved. After this collaboration, clearly define the chosen treatment plan. In the majority of cases of an older adult nearing the end of life, palliative care and often hospice care are highly recommended to be incorporated into the treatment plan. It is important to clearly describe both the differences and similarities between the two, as many patients incorrectly conflate them. Explain that palliative care is a medical specialty from which all patients with life-threatening illnesses are eligible to receive treatment, regardless of prognosis. Palliative care specialists provide symptom relief, whether physical, psychological, or otherwise, and often do so in conjunction with curative treatments. They aim to improve quality of life for patients and their families, and practice in both the inpatient and outpatient setting. Hospice, on the other hand, is a Medicare benefit, and only patients with an expected lifespan of 6 months or less are eligible to participate. While hospice is similar to palliative care in that they aim to improve quality of life, hospice initiates a move toward comfort care and away from interventions that do not improve quality of life, even if they could prolong life. Hospice offers both inpatient and home care services. For both palliative care and hospice, it is very important to emphasize to patients and family that neither hastens death. In addition, research has shown that they can also help us achieve our goal of reducing unnecessary healthcare utilization, including bounce-back emergency department visits and hospitalizations. Now to summarize what we have learned. Older adults frequently visit the emergency department in the final months of life, and as a result, many are admitted to the hospital where they may die. Emergency department visits and hospitalizations increase end-of-life costs, but not necessarily end-of-life quality. To address this problem, as an emergency department provider, it is important to be able to identify patients at or near the end of life, and if needed, initiate a goals of care discussion. Finally, we learned that involving palliative and hospice care can help minimize unnecessary and unwanted healthcare interventions. Thanks for listening, and I hope you learned something new today.